All right. I am very sorry about that. I have no idea what's wrong with this computer, but the very good thing is that now we have slides. So I don't know what's going on. Technology is great until it isn't. Okay, so I'm going to go ahead and hopefully the student who was in the meeting will come back. I don't know if she will, but hopefully. So I'm going to share my PowerPoint slides with you guys, and I am going to pick up where I left off. Thankfully, we did not get into schizophrenia yet. So we are going to start there. And I'm sorry again for this ridiculousness of this computer. I have no idea. It's the first time that's happened. So I guess there's a first for everything. Okay, so schizophrenia. So I just talked about dissociative disorders and specifically dissociative identity disorder. And when it comes to schizophrenia and multiple personality disorder, a lot of people get those two confused. And it really is a matter of the fact that they are two different disorders altogether. Dissociative identity disorder is dissociative identity disorder is multiple personalities. Schizophrenia is one personality shattered. It is where you have serious distorted perceptions and beliefs, thought processes. You can have two people can have schizophrenia and have two very different presentations of the disorder. There are a lot of similarities across many cases, but the idea of schizophrenia is pretty broad. But it all comes down to this kind of break with reality and shattered personality. Now, in order to be diagnosed with schizophrenia, you have to have at least two or more of the characteristic symptoms, which we're going to talk about those, present for at least a month or longer in order to have this diagnosis. If you look at the picture to the left here, it's very odd, but what this is it's a woman, Karen Sorensen. She's an artist who has schizophrenia. It's managed. And it's managed with medication. She painted this picture, and she refers to it, and she calls it "Electricity Makes You Float," and it's really how her interpretation of how she felt during the World Trade Center attacks at 9/11, and so we find that there can be a lot of really interesting artistic interpretations when you're in different states, especially with mental illness. But I thought this was a really interesting sort of perspective when it comes to this particular disorder. Now, before we get into the symptoms, I want you, wherever you are, whether you're at home or you're at work or whatever it may be, I want you to take a moment and I want you to pick something up that's close to you. So if it's your phone, if it's a pen, something, okay? And I want you to hold that item in your hand. It's got to be something that you can kind of hold, right? And I want you to look at it. I want you to examine it. If it's got words on it, I want you to kind of see the words. If it's got colors, I want you to pay attention to the colors. How does it feel in your hands? Is it light? Is it heavy? Is it smooth? Is it rough? Is it hard? Is it soft? How does it feel? And I want you to really get all those little tiny pieces, every little characteristic that you can kind of think of. Are there sharp edges? Are there not? And I want you to think about the fact that I might come up to you and say, "What are you holding?" And you'll say, "I'm holding a pen or my phone." And I might say to you, "No, you're not. There's nothing in your hands." Now, your first thought might be like, that's stupid. Of course there's something in my hands. I feel it. I see it. I can smell it. I can do all of these things. And then I say, "Well, maybe, but there's nothing in your hands." Well, your next inclination might be like, "She's weird. She's crazy. Let me ask this person next to me, do you see this? Can you feel this?" And what if that person was like, feel what? There's nothing in your hand. Well, then you might go, well, this is dumb. People are on to something. They're not, this isn't, no, this is dumb. Okay. And then you go to somebody you trust and you say, do you see this? Because you start getting a little paranoid. You're like, well, two people just said that they don't see what's in my hand. And then if somebody you trust says, there's nothing there, how do you think you would feel? You might go, am I starting to go crazy? Are people around me going crazy? Like, what is going on here? You're going to start questioning stuff. Well, if this isn't real, then is this real? Is this real? Am I real? Do I have clothes on? Like, what is going on? And so this is reality. Everything around you, the clothes on your back, the jewelry on your hands, the phone right next to you, the glasses on your face, the hair on your head, all of these things are your reality, but they're also confirmed by other people. Your reality is always confirmed. You smell a weird smell, you say, hey, you smell that? Someone's like, yeah, I smell it. And then you stop questioning it. You never question it because there's always confirmation from someone else. When it comes to things like hallucinations, imagine that someone tells you it's not real. And someone says to you, it's not there. But you say, I smell it, I feel it, I hear it, I sense it. And the person tells you it's not real. You're going to then question everything. You are going to question your own reality. You're going to question everything around you. And you're going to get to a point where you don't know what's real and what isn't. And that's so frustrating because hallucinations aren't just you see something. Hallucinations are you feel it, you smell it, you sense it with just more than one sense. You might hallucinate that there are ants or spiders crawling up your leg. You can hear them. You can feel the sensation go up your leg. You can smell the smell of insects. And someone's telling you there's nothing there, you're fine. But to you, it's your reality. That's incredibly scary. And that's what people with schizophrenia who have hallucinations experience. They experience lots of different types of hallucinations and lots of different types of symptoms, with hallucinations being very common. But to them, that's their reality. That's what they're experiencing. That's what they're feeling. And so when you're told that you're wrong and everything points to you're right, it can get very confusing to deal with all of this. Now let's talk about a few of the positive symptoms when it comes to schizophrenia. So of course, a person can have delusions, which are false beliefs. These can be delusions of grandeur. They might think that they're the president. They might think that they're Gandhi. They might think that they're God. They think they're really important. They think that they're, more than what they are. They might have a delusion that they're somewhere where they aren't. They might get confused and think that they are in church or they're in a bathroom or they're not really quite sure what's going on. These can lead to really dangerous behaviors because if they have, for example, delusion of persecution, they might think that someone's out to get them. And this might cause them to act very paranoid and even jump out of windows if they feel like, somebody's out to get them. Also, they can have hallucinations, which are also false perceptions. So these are any kind of any sense, right? Any perceived sense. Smelling, they might smell gas and think someone's trying to kill them or poison them. They might hear voices. It's very common. They might see, people. They might think someone's out to get them if they're paranoid. And these can be very indistinguishable from reality. Like I said before, you're telling somebody this is not real and that's what they're feeling, and it's very, very frustrating. A lot of times we see disorganized thought, disorganized speech. It doesn't make sense. The words are there, but they're not in the right order. And disorganized behavior. So the person's not acting correct for the right context. They might be laughing at a funeral. They might be crying at, a very mundane sort of activity, like washing the dishes. Um, any positive symptom in anything in psychology means it's the addition of something that shouldn't be there. So positive we think of a lot of times as a good, right? So, in the dictionary, in our lives, when we say that's a positive thing, usually we mean that's a good thing. In psychology, positive means the addition of something, and negative means the subtraction of something. So when I say positive symptoms of schizophrenia, I mean that there's additional things, additional symptoms that should not be present. You should not hallucinate. You should not see things that aren't there. You shouldn't hear sounds that aren't there. You shouldn't believe things that aren't true, right? And that's what positive symptoms are. Now, you can also have negative symptoms, and we'll talk about those in just a minute. Now, when it comes to what kinds of hallucinations a person with schizophrenia might experience, you can see here that the majority of the kinds of hallucinations that people experience are auditory. They might hear voices, they might hear a baby crying, they might hear something that isn't there. 27% are visual, so it's a large portion. They see things that aren't there. 15% being tactile, they feel something that's on them, or maybe they're holding something that they feel in their hands. And then 11% is smell or taste. And so these are really common types of hallucinations that people with schizophrenia might experience. Now, the interesting thing when it comes to what's happening in the brain. So this right here is a PET. There's a 1995 a PET scan a research project was run where they used positron emission tomography, which is PET, and it's a brain scanning technology that allows you to follow metabolic activity. It takes snapshots of the brain. You can have people doing things and saying things and experiencing things, and you can take a snapshot of what the blood flow or metabolic activity or whatever looks like during that time period. So MRI, or magnetic resonance imaging, is a type of imaging that looks at blood flow. You can do functional imaging, which actually looks at blood flow during and oxygen during a particular activity. And so the way that fMRI works is that it's based on the idea that your brain is constantly needing a supply of oxygen for energy. And so it looks at the rate of blood flow when you're doing certain activities. PET is actually gives radiation, and so you can actually give a person a radioactive dye in their bloodstream to track certain kinds of metabolic processes. And this particular study was able to look at the kinds of activity, areas in the brain that are doing things while a person with schizophrenia was hallucinating disembodied heads yelling orders at him. Now, if you look at this brain, the parts that are yellow and orange are the parts that are more active. These are the parts of the brain that are getting the more metabolic activity, and they're actually doing something. And so what they found in that study is that there was left auditory activation, and the visual area, which is in the back of the brain, back here, this is the back of the brain. I think, let's see, let me get the pointer out. And so the back of the brain is right here. Okay, and so this is our visual center. So our eyes are here, and there's a link to the visual center here, and this is where we process visual information. And so the visual information is the visual part of the brain is being activated, and then the auditory part here in the sort of temporal area is being activated. And what this is showing, so here and here, for example, especially right here, what we're seeing here is that the activation is actually completely in line with hearing something, right? So we're actually seeing in the brain the right kind of activity for actually hearing something. What's missing is activation here. Activation in the frontal lobe. This is our organized thought process center where we are logical and we can make decisions and we think through things and tell ourselves that what we're hearing isn't real. When you don't have this activation and you just have the auditory and the visual stuff going on, what that's doing is that's essentially, it's not the right kind of pattern of activation. And so it will tell us that something is going on in the brain here, but it's not typical. So this could explain, this idea of what a hallucination is. It's actual brain activity, but with the lack of the frontal lobe activation, we're not getting the message that it's not real. And so that's an interesting it's a really interesting study to see what happens in the brain. Now, we talked about positive symptoms, and you can have negative symptoms too. So negative symptoms, anything that's missing, right? So it's a decrease or a deficit in a behavior or an emotion that is supposed to be there but isn't. Now, these can occur together, and because there are some differences in how cultures express emotion and what's acceptable, there are some differences across cultures, but we do see these sort of things across the board. So flat affect is when you don't have the emotion, or you don't have any emotion, or you don't have the emotion that's expected. And so when you, for example, you might have somebody who's in a situation where you tell them, your grandmother died, and the person, if they have flat affect, would just be completely emotionless. You might say your dog died, and they just won't give you the right reaction. They don't seem to have any emotion. And you might tell somebody something very funny, and they won't laugh. It's just a complete lack of emotion. Alogia is a lack of speech. And so this could be complete muteness. This can be somebody who is just not responding at all. They might be mumbling or but they're not responding to you, or they're not talking at all. Avolition is lack of motivation. And this isn't just like, ugh, I don't want to do that activity. I don't want to do my homework. This is such a lack of motivation that they don't eat, they don't bathe, they won't get up to go to the bathroom. They will avoid their bowels on themselves. If they fall in a pool, they might not swim up to save themselves. It's a complete lack of motivation in a really excessive way. There is and when you have a case where somebody is really severe and has avolition, what you might find is that the person actually starves to death because they don't feed themselves, or they are completely neglectful, and they might have sores because they refuse to get up off the chair. They won't get up off of a chair, out of the bed, or something like that. So this can be really, really dangerous. There's a link here with 4 different patients to show you what schizophrenia can look like. It's a really interesting sort of case study. You'll kind of see some examples of paranoia. You'll see some examples of behaviors that are like catatonic, where a person isn't really moving, they're just very still. And you can see that with avolition, where they're catatonic and then they don't they're just sitting there. They won't eat, they won't drink, they won't move, they won't do anything. Very interesting stuff there. So if you want to check those videos out, that video out, I really suggest that you do that. Now, of course, when it comes to this particular example, there is some adult language in it. So just fair warning there, if that bothers you, then you might have an issue with that. Now, just looking at the kind of breakup when it comes to positive versus negative symptoms. When it comes to this particular graph was an incidence of positive and negative symptoms in over 100 people who were hospitalized for schizophrenia at one time. And so you can see that for positive symptoms, about 81% were experiencing delusions, 58% hallucinations, 22% of those were experiencing disorganized thought. And so that's all lumped into the positive symptom category, because remember, positive symptoms are the addition of something that shouldn't be there. Negative symptoms is when you have the removal of something that should be there. 65% were experiencing flat affect, 30% poverty of speech or muteness or lack of speech, and then 85% had some form of apathy or avolition, issues with motivation, and these are actually pretty common when it comes to people with schizophrenia. Now let's look at the prevalence. So about 200,000 new cases are diagnosed in the US per year, and about 1 million Americans are treated annually. This is about 1% of the population, and interestingly, this is pretty standard when it comes to looking at different cultures. So it looks like there's about a 1% prevalence rate for all cultures, so it doesn't seem to affect one more than any other or one less than any other. Um, when you look at diagnosis, usually we see that schizophrenia is diagnosed in young adulthood. We see that in those cases, the parents or the guardian might say there were a lot of signals that told us that something was off when the person was a child. There might have been red flags and issues, but it seems to be that puberty really kind of triggers a lot of different mental health conditions. But we see that in schizophrenia, it tends to be diagnosed in young adulthood, 18 to 21 or so. We're seeing that that's usually when we see the first psychotic break. Now, when you look at looking at 100% of the people who are diagnosed with schizophrenia, a quarter of those people, so 25 out of 100, will have a psychotic break. They'll have the symptoms of having a particular episode, and then they will recover completely. They'll never have a problem ever again. It's managed. It's fine. They had the psychotic break, and they're healthy, and they're okay. But that's only a quarter of the people who are diagnosed. Another quarter will have reoccurrent episodes, but it'll be manageable, and the episodes are they might impact them at the moment, but overall their ability to function is not impacted. They're able to hold a job, they're able to manage with medication, and they're managing their disorder. The other half, so 50 out of 100, we're looking at a chronic mental illness. Ability to function might be really severely impaired. They may not be able to have a job. They may not be able to function in society properly. They will likely spend a lot of time hospitalized during different breaks. And even though at some points medication might manage their condition, they really do have issues with functioning in society. So it is a very impactful disorder for a lot of people who are diagnosed. Now, how do we develop schizophrenia? When you look at different family studies, for example, you look at who has schizophrenia within a family. If a mother, father, uncle, grandmother, whatever has it, then you do tend to see that more than one family member may have it. And so there's thousands and thousands of genes and gene variations where we think that there might be some sort of genetic link, because we do see a pattern where it does tend to happen in families. We also think that there might be a genetic common origin with bipolar disorder. Some of those genes might overlap. There have been twin studies to look at identical twins. So if the twins share the same DNA, right? So 100% of the DNA. If one twin develops schizophrenia, the other twin is much more likely to develop it. And if we have a fraternal twin, so that means that they don't share the same DNA. They're basically like siblings, but they share the same womb. They do have an increased risk if one twin has it. It has an increased risk of the other twin having it, but not as high as if they were identical twins. And of course, the adoption studies show that it is more likely genetic than environmental, because we can look at identical twins separated, brought up in different parts of the world with different families, and we still see a rate that twins, if one twin has it, the other twin is going to have it regardless of where they grew up. Interestingly, when we look at maternal age, so how old was the mother when she conceived and carried the child in the womb, maternal age does not seem to have an impact on the likelihood of developing schizophrenia. It's actually the father. It's paternal age. It's one of the few where we actually see that as the uh, as the age of the father increases. So as the father is older, when he and when he has the blanking on words here. Oh my goodness. It was the computer. I'm telling you. When his sperm, meets the egg at conception, fertilizes. Oh my God. Okay, there's the word. Okay. When he fertilizes the egg at whatever age he is and the sperm is, that actually has more of an impact. So when you look at groups of fathers who are younger than 25, when you make that comparison as sort of the baseline, fathers who are 45 to 49 years old, who conceive and fertilize an egg, their children are twice as likely to be diagnosed compared to fathers who are 25 at the age of conception. Whereas if you're 50 and older, there's 3 times likelihood for that child to be diagnosed. So it could be something's happening with the sperm and the quality of the sperm that's has something to do with, might be triggering this particular disorder. Another interesting thing is this of the immune system and the viral infection theory. And so the idea is that if a woman is pregnant with a child and she's exposed to the flu virus during the first trimester, that child has a 7-fold risk of developing schizophrenia. And so the idea is that the woman is exposed to a virus, the flu virus, and that virus is crossing through and affecting the development of the child, and or in this case the fetus. And then later on there's something that's happening in the brain that is going to that virus is triggering, that's going to lead to an increased risk of diagnosis of schizophrenia. They also call it a seasonal effect, where you find that because we look at flu season being, in particular certain months, we see that babies born in around April or in the spring tend to actually have an increased risk of being diagnosed with schizophrenia at a later time. So very interesting thing. And we see a seasonal effect happening in a couple of other disorders, but schizophrenia is one that's more well known. Now, abnormal brain structure, there's not a lot here. There's a little bit of differences in the ventricle size and the amount of gray matter volume that's in the brain. But the unfortunate thing is that we don't know if it's sort of correlational. So we don't know if it's just related or if it's causing it. So we don't know if the schizophrenia is causing the decreased gray matter volume, or it's the gray matter volume that's causing the schizophrenia, or there's some third variable or fourth variable that's causing them both. It's all just sort of correlational. The ventricles we see tend to be enlarged in a person with schizophrenia. Again, we don't know if that means that one's causing the other, or if it's simply just an issue with there's some other variable causing all of it. Schizophrenia is not, it was once thought of, just a person's in a traumatized environment, so they're going to develop schizophrenia. That's not necessarily the case. There's definitely a genetic element to it. And it's not a trauma-caused disorder. It's a mental health disorder that's got a lot of very complex things going on in the brain. And so this brings us to our review slide, where we talk, we've covered the dissociative disorders in schizophrenia. The other slides cover the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders. It's the 5th edition, talking about anxiety disorders. If you review the slides, you'll see there's a lot of text on them: OCD, major depressive disorder, anxiety disorder, bipolar disorder. And then there's a chart of the personality disorders. And you can Google DSM-5 and then the different personality disorders to see the list of symptoms that go along with those personality disorders. But the interesting thing about personality disorders is that most of the time people actually have no idea that they have them. And so the problem is, of course, that most people with personality disorders never go and seek help because they think nothing's wrong with them. And it's the people around them, the family members, the loved ones, the bosses and their, coworkers who say, no, something's wrong with you. You need to go get therapy, or in order to save this relationship, I need you to go see a therapist or counselor, or to keep your children, you need to go and get mental health counseling. So with personality disorders, these are very pervasive. They tend to, those individuals tend to not seek out help because they think that they're normal and fine. Or they might think I'm not normal, but whatever, I'm fine. I am who I am. So if you have any questions, please feel free to email me. I'm happy to respond. I'm sorry for the technological issues, and I am sorry to the one student who was in the room, the Zoom room, and it disconnected. So hopefully she'll be able to watch after. But if you have any questions, please let me know. I'm happy to answer them. And if you're doing the Star Wars activity, remember that just because a person has certain symptoms doesn't necessarily mean that they're definitely having that diagnosis. It's very difficult to diagnose people because you only get parts of the story. But do your best on that activity. And you can use Google. You can, if you suspect a particular disorder, Google the disorder with DSM-5, and that will pull up the symptoms. Use the slides to help you. Just do the best that you can. It's not meant to be an anxiety-provoking activity. It's meant to be more kind of an interesting, kind of fun take on diagnosing. And probably will also teach you that diagnosing is actually really difficult, even when you are familiar with the characters. So everybody have a great day. Email me if you have any issues, and hopefully you enjoyed today's lecture.